Hey everybody. So I thought I would introduce you guys to Miss Bella, since she's who I talk about on the lives a lot of the time, and who was born at the Holston Valley NICU. So I'm going to give it just a second for folks to hop up in here and for you guys to meet this little one, and then I'm going to give you the peds information that I was trying to give you earlier and just didn't have enough time to get it all together and that sort of thing. So I'll give it a second for folks to pile up in here. And I just want to clarify some of the information that I gave earlier today. I have taken that live down just because there was some confusion when people messaged me afterwards. So I wanted to just be very clear, because accuracy is extremely important to me. And I want to make sure that the information that I give you is correct, and that I'm not so like going nuts with everything that's happening that I'm not giving it to you. So this is Bella. She was born at 1 pound 3 ounces at Holston Valley NICU. So when people ask me, you know, why am I so passionate about what's happening here, and why do I, why do I care so much? This is the reason why. Bella, can you say hi? Say hello. Say hi, Mama. Say hi. I know. Can you say hi? Okay. So, thank you guys. She is 15 months, 12 months adjusted at this point. She's doing really, really well, and amazing considering everything that we went through. And it's one of the reasons why I'm so adamant about the changes that they are trying to incorporate. She's definitely a miracle baby. She had a moderate sized hole in her heart at one point. She had like digestive issues. We had, because she was in the NICU for so long, she had the film that can kind of grow over your eyes, and we thought potentially she was going to have eye surgeries and all of those types of things. And so I'm 100% positive that she was born exactly where she was supposed to be born, and that without the folks at Holston Valley, we wouldn't have her here. Like, between Holston Valley, Dr. Powers, all of our nursing staff, and God, of course, like, that's how we still have her. But so the information I did find that I wanted to give you earlier, awesome, Tanya. See, then you know exactly what I mean, right? But the information that I wanted to give you earlier that I couldn't lay my hands on, I had already printed out. So when I was looking for it electronically, that was the problem, is because I'd already printed it out and already closed it down. So then I was struggling to find out what I really wanted to give you before. So here we go. So what you have heard is, you have heard Alan Levine reference this volume criteria from the American Association of Pediatrics. And what he has said is that basically NICUs that have the highest volume have the best outcomes for babies. And there are studies that say, yes, you do want to have, a higher volume of NICU babies, just because that makes sense. Anything that you do more of, right, you do better at, typically. So, if you service NICU babies and you have 100 babies versus 10, obviously you're going to do better at those 100 babies. Now, here's the thing. What the studies show is it talks about having 100 or more babies, which Holston Valley does do. Last year, they did 268 babies. This year, they've done more than that already. So it's not that there's a low percentage of babies. When he talks about a daily census of 7, which last week it was a daily census of 9, and then earlier this week it was a daily census of 8, he keeps changing those numbers because they keep reducing the number of babies being sent to Holston Valley. Previously, what was happening is babies that were born in Bristol were divided up. And so some would go to Holston Valley, some would go to Johnson City, and it just depended. And I'm not saying that there's anything wrong with Niswonger's NICU. That's not what I'm saying. What I'm saying is that there's a definitive need for the NICU that's in Holston Valley. And I want to give you some information that's also from the American Association of Pediatrics. So if you look, this is the document that I printed out. As you can see, it's the levels to neonatal care. This is from the American Association of Pediatrics. So this is the same document that Alan Levine keeps referring to when he's talking about volume. Now, here's what I want you, I keep saying association. It's the American Academy of Pediatrics. So here's what I want to give you, okay? So I want to make sure. All right, so the first thing that I want to give you is a study that was talking about, it's Laswell et al. Reviewed 41 English language U.S. and international studies, right, which included more than 113,000 very low birth weight babies, which very low birth weight babies mean that it's less than 3.3 pounds, right? And what they found was that very low birth weight infants born at non-level 3 hospitals had a 62% increase in odds of neonatal or pre-discharge mortality compared with those born at level 3 hospitals. So here's what we're talking about. This is directly from the same document, the same organization that Mr. Levine keeps talking about volume. So follow me. It's not just about having these babies transported there. It's about making sure that they're there in a timely manner where they can actually be born at a level 3 facility. So if we know that if they're born outside of a level 3 facility, they have a 62% increase in mortality rates, why would we ever want to get rid of a level 3 facility that's operating, that has staff, that has experts, and that has a decently high volume of babies? Like, that just doesn't make sense. You see what I'm saying? So that's the first statistic that I want to give you. And I'm going to read it one more time. Hold on a second. You trying to get down, sissy? Y'all ever try to do a live with a 1-year-old? Okay. So, yeah, I got it. All right. So here's the deal. So I want to give it to you one more time, and I apologize for moving around, but I got a baby in my hands. So here we go. So I'm going to repeat it. Here's what they found. They checked out a study, studies that had over 113,000 very low birth weight infants, and found that those infants that were born at non-level 3 hospitals had a 62% increase in the odds of neonatal or pre-discharge mortality compared with those that are born at level 3 hospitals. The bottom line is that statistic alone should tell you we don't want to reduce these women, these mothers' ability to give birth at a level 3 NICU. The bottom line is we have 2 level 3s. Why would we want to get rid of one of them if we know that by getting rid of them, we increase the chances of 62% of these babies dying? That's just not something we want to do when we talk about lives matters and babies matter. The second thing that I want to give you is that it also talks about some of the difficulty in collecting evidence to provide accurate assessments of very, very low birth weight outcomes. It's been in attaining appropriate standardized measures. So guys, these levels of NICUs and the standard terminology, making sure that all of the hospitals are using the same designations, the same standards, the same terminology, it's just not been happening. That's been a really, really tough thing, right? But here's the one that I want to tell you. So heterogeneity among studies on neonatal levels of care suggests the need for a quality standard for comparison, which includes the following elements, right? Population-based studies within well-defined geographic regions. So follow me. They're saying, listen, these are guidelines that we're talking about here, but it's important that we realize that these things are going to differ based on these 3 things. So you want population-based studies within well-defined geographic regions. You want clear definitions of the intervention or the hospital level of care. And you want an appropriate adjustment for confounding factors to include maternal, social, and demographic risk factors, pregnancy and perinatal risks, and severity of illness at delivery. So listen, when you start talking about what the guidelines are, the guidelines aren't specific to this region. And that's one of the problems that I have with him just throwing out this volume number and what we want having happen. This is not a metropolitan area. This is not Charlotte. This is not Atlanta. This is not the same as those things, because even though those things may only have like a level 1 trauma center, or they may only have whatever, they have other designations and other specialty and other subspecialty doctors and physicians and surgeons that can support that one area. It's not the same when you're talking about rural hospitals and rural communities. And so this is one of the things that they say. They say, listen, even though this is what studies show, we have to understand that there's not continuity across the line in making sure that we're comparing the same information in the same regions. So check this out. The authors also found that the percentage of very low birth weight infants delivered at level 3 centers, really, Bella? She just came like headbutting over here into the picture with me. So if you have them born with greater than 100 babies, annual admissions, it would prevent 21% of the deaths. She is all up in here. So you're going into labor early in big summer in bad weather. Yeah, I know, Terry, exactly. And that's one of the things that we're talking about here when we talk about That light is super, super bright, isn't it? Hold on. Ugh. There, that's better. So, yeah, so she's all up in here with me. But anyway, okay, so the bottom line is that it can prevent, this was a study that they did, right? I know, Amber, she's all up in here. Just say hi, honey, because she's not going anywhere, and it's okay, right? Here's the thing. I'm so very grateful for this kiddo, right? Like, she's the reason that I'm fighting. Well, part of the reason why I'm fighting so hard, because without thank you guys, without the NICU at Holston Valley, we wouldn't have her. It's just that simple. Okay, it's just that simple. And okay, so here we go. Let me keep going. So listen to this. Other studies assessing NICU volume suggest caution in using just volume in measure as an effective indicator of quality of care. So that's one of the things that I really wanted to point out to you guys, is that when we talk about using volume, right? Because listen what it says. It says a population-based study of 4,379 very low birth weight infants who were born between 1991 and 1999 evaluated the mortality in relation to both annual volume of births and NICU volume, right? Here's the thing. It literally says, they go on to say, listen, other studies assessing NICU volume suggest caution in using this measure as an effective indicator of quality of care. It's not just about the volumes of babies. There's a lot more that goes into it. And this is the same guy. This is the same American Academy of Pediatrics that Levine is quoting when the same thing. It says, listen, yeah, there are studies that show that volume matters. And then they say, listen, while there are some of those studies that show volume matters, that's not the only measuring tool. And you should use caution when you're just using volume to justify or to predict the outcome of a NICU center, because there's so much more that goes along with that. Sorry, guys, let me move from in front of this light. So check this out. And here's why they caution against using just volume. They found that although annual volume explained 9% of the variation in hospital mortality rates, other hospital characteristics explained another 7%. So what they're telling you is, listen, even though, say hi, Mandy. Mandy was one of your, yeah, Mandy was one of your nurses. Say hi, Mandy.
Yeah.
Yeah, say hi, Mandy.
Hi, Mandy.
That's my niece, Paris, talking about hi, Mandy. He does like to pick and choose what he uses from that. And so this is why it's important. This is why I want to pick the other things that people need to know, because when you just hear it, it does make sense. It does make sense that higher volume is helpful, but it's not the only characteristic. She's trying to take off my bandana. The other things that we want to take into account are, you know, the staff and the expertise and, you know, their bedside manner and how much knowledge and how much experience do they have and how much access do parents have and mothers have and kangaroo care and skin to skin time and all of those types of things, right? So check this out. I want to give you another one that I had highlighted from here. Several studies have compared the short-term outcome of very low birth weight infants born in centers with level 3 units compared with those that are born at lower level centers and then soon transferred to a higher level center. So remember how he keeps talking about our ability to transfer, our ability to transfer, our ability to transfer, right? Many of these studies are retrospective and may be subject to selection bias because infants who were transferred most likely had the highest chance of survival and thus gave the impression of lower mortality. So check it out. He's right. If your baby is born at a level 1 or a level 2 NICU, like a well nursery or a special care nursery, and then transferred to a level 3, the outcomes are going to seem higher simply because babies with the greatest chance of survival are the ones that are transferred. I guess Bella's feeling pretty passionate about this subject, right? I get it. See, and that's the thing, Nancy, that this is what we're trying to say is that, hey, Freddie, I definitely will. This is what we're trying to say is that time does matter, and transfers aren't necessarily the best solution in terms of saying, oh, well, if you transfer, they're going to have a better outcome, because they were already, that skews the numbers a little bit, right? So we got to be careful in how we use the data. Now check this out. Evaluating and controlling for confounding variables and case mix presents another set of challenges because these factors vary by population. For example, listen to this part. Race and insurance status may have more of an effect on birth outcomes in the U.S. than in other countries. So this is the thing. This is going to sound really funny, but I want y'all to hear me. They told us that when we were in the NICU, they were talking about different races tend to do better in different NICUs, in NICUs. And they talk about insurance capacities because certain insurances are okay with certain things and not okay with others. So those things actually play into the data and play into us when we're talking about outcomes, okay? This one is another good stat that I wanted to give to you guys. What we want to have happen, there's a goal. It's called the Healthy People Goal, the Healthy People of 2010. The goal is to have at least 90% of very low birth weight infants delivered at high-risk facilities. This is, why would you eliminate a facility if we know that this is like the goal? The goal is to have 90% of babies that weigh less than 3.3 pounds born at a level 3 facility, right? Like that's the goal. You want them at the best facility possible, and you're literally taking that away and making it harder to have that happen. So instead of us having 2, you're now going to take us down to 1, which makes absolutely no sense whatever, and it makes it very, very hard. I will tell you this, so check this out. Nancy, they are already diverting births from Holston Valley. They are already diverting births. There are, and I'm just going to tell you what I've been told. What I've been told is that about half of the babies from Holston Valley are now being delivered elsewhere at this point. Here's what I can tell you. I did visit Holston Valley the other day. I do that every time I come into town. I was followed by security while I was there. They were not happy to see me on the grounds. So here's what I can tell you is that when I did go onto the 3rd floor at Holston Valley, the lights were dark in the halls. There were no ribbons on doors. The last time I was there, almost every room. Really, Bella? Say hi, for goodness sake. Say hi. Hi. Say hi. Say, leave my nurses alone. Say, leave my doctors alone. Say, they saved my life. Leave them alone, bad man. Tell them. Say, money is not more important than me. Tell them, say, money is not more important than me. So I did go up there, and it was really, really quiet on the floors. And, you know, normally it would be packed. So they have definitely been diverting babies and diverting NICUs. So here's the thing, Terry. Are you talking about between Johnson City and Holston Valley? I'm not sure what those are, and I'm pretty sure nobody's going to give me that information. But I want you to know that the overall goal is to have 90% of these babies born at high-risk facilities. And when you reduce these NICUs from level 3s to level 1s, they are simply well babies. They're well baby centers. It's not. There's nothing there. So yes, sir.
I'll play the game that we're playing.
Okay, give me a second. So this right here is my grandson. Say hi, Dominic.
Hi.
So this is Bella's big brother. This is Bella's big brother and my first grand, okay? So let me see what else I want to give you. So let me tell you the classification when we talk about levels in terms of NICU. Level 1, a level 1 NICU is provide neonatal resuscitation at every delivery. Like that's all that's there. I don't know why this is asking me if I want to tag somebody in this because I do not. Hi, Bella. You trying to get all in my face? She's literally trying to pull my arm down. So the provider types for a level 1 NICU are pediatricians, family physicians, nurse practitioners, and other advanced practice registered nurses. It's considered to be a well newborn nursery is a level 1. Their capabilities are to evaluate and provide postnatal care to stable term newborn infants. Stable term newborn infants, right? Stabilize and provide care for infants born that are 35 to 37 weeks in gestation who remain physiologically stable, and to stabilize newborn infants who are ill and those born at less than 35-week gestation until transferred to a higher level of care. That's it, right? But you hear the provider types that are there. You don't hear any neonatologist. You don't hear a neonatal nurse practitioner. You don't hear that neonatal component required for a level 1. You do have them required for a level 2. And of course, you still have them at a level 3. So one of the things that's important to think about when we talk about Holston Valley, a lot of the babies that they get do come from the Indian Path and surrounding areas where you have some of the drug exposed babies that end up having issues that even though they might be full term, they have, you guys correct me if I'm saying it wrong, it's NAS, whether you're saying NAS or NAS. And so you want to be thinking about those babies that are drug exposed, and they have to go to Holston Valley, period. Let me keep going. So, level 3 NICUs have to have a pediatric medical subspecialist, pediatric anesthesiologist, pediatric surgeons, and pediatric ophthalmologists. NAS, thank you, Terry. So there's a big difference between what Holston Valley currently has and what they would be going to. I want to make sure I don't have anything else that I wanted to give you. No, those were the biggest things. So using the same document that Alan Levine keeps quoting in reference to volume, there's a clear indication that, Nancy, I don't know that. And and they're not giving me a ton. A lot of the information I'm getting isn't coming directly, like they're not going to give it to me, right? But I'm getting information. So I don't know exactly. What I can tell you is that there are a lot of Kingsport babies now being born in Bristol. And I would think Johnson City, but I don't know. So don't quote me on that. What I can tell you is that they have dramatically reduced without state approval. Without state approval, they have already been diverting babies from the Holston Valley NICU and from labor and delivery there to Johnson City and so forth and so on. If you need my secure email address, you can just send me a message on Facebook and I will give you my secure email address to send me, and you can message me on here as well, and we'll figure out whether we need to do a phone call, an email, or all of that and all of that sort of stuff. Right, correct. Mike, are you referring to Dr. Powers at Holston Valley? Yeah, Donna, so that's something that that is something that I've talked about, and I've actually been given documentation to the effect that 25% of the babies born at Indian Path are drug exposed. So yeah, so that's like a fact. So just so you guys know. But that's really what I wanted to give you guys in reference to the AAP and their guidelines and what they say. Right. And what they say, I believe right now we have a Bella. We do have a pediatric surgeon who is in Johnson City. What she is not is she's not a pediatric trauma surgeon. There's a distinct difference between those two things. She is a certified licensed pediatric surgeon. She's just not a trauma surgeon, which is something completely different. So in the information that I was talking about earlier today, when it comes to these pediatric ERs and a pediatric trauma facility that you've heard them talking about doing, and they've talked about the fact that we have 20,000 pediatric ER visits. The pediatricians have told Ballad Health that those 20,000 visits were more along the lines of pediatric urgent care needs. They were not pediatric trauma patients. And the ability and the availability of pediatric trauma surgeons is extremely limited, especially to come to a region like ours and that sort of thing. I mean, like the nurses right now are starting out at just shy of $18 an hour, which is ridiculous because you can work at PALS and other places like that and come close to that. So it's why a lot of the nurses who are graduating aren't staying here. It's why a lot of nurses have already left. And the facilities that we do have are understaffed. They're definitely understaffed. Well, so, and I did go over the Ballad board of directors, and I went straight off their website. What I can tell you is that on the Ballad Health website, the only board of director who's actually a medical doctor is Dr. Mays, and he's an anesthesiologist. That's it. He's an anesthesiologist. There's nobody, when Mr. Levine says, you know, I report to a board and the board is solely behind this, it's not just me making these decisions. Understand that board, they're not medical. One of them is a senior VP from Eastman that's on the board. Somebody else, there's two people that have a background in accounting. There's somebody else who's from ETSU. There's somebody else who used to be over the Kingsport Times and the newspaper. But yeah, they're not doctors. They're not doctors. The doctors in the area have spoken out very emphatically. Dr. Powers and Dr. Spivey both have spoken out very emphatically about the needs of this community and what's not happening. And you guys even saw Dr. Yusuf's write-up in the newspaper and what she thinks about these proposed changes. So it's really important that when we start quoting statistics, no ma'am, those are my glasses, thank you. When we start quoting statistics from guidelines and journals, it's important for us to understand that those are just that. They are guidelines. They have nothing to do with this particular area, with this geographic region, and all of those types of things. So I wanted to make sure that I gave you guys that information. I wanted to clear up if there was any confusion about what I said concerning the pediatric surgeon in Johnson City. She is a certified pediatric surgeon. However, she is not a certified pediatric trauma surgeon, and that's the difference. That's the distinction that I was making earlier. I was in no way, shape, or form saying that she was not a certified pediatric surgeon, because she is. The trauma is the specialty that I was talking about in reference that. Yes, Karen, I will throw up my PayPal info again. I can tell you it's paypal.me /tcook, T as in Tom, COOK 333. That's me. So paypal.me /tcook 333. So that's me. So I will be at the Scott County meeting Monday at 2:00. I will be there for that. I am putting together information and packets for all of the county commissioners, the aldermen that have asked me to email them, and so here's what I do want you guys to understand. It is about more than just saving the NICU and the trauma centers. So listen, they want to take the level one trauma from Holston Valley and reduce it to a level 3, and they want to reduce Bristol from a level 2 to a level 3. When you do that, that means you go straight from a level 3 to the only level 1 being in Johnson City, and we leave Southwest Virginia with no trauma center whatsoever. Right now, from Smith County all the way down to Bristol and Southwest Virginia, you have no trauma centers at all, folks, and you have no level 2 or level 3 NICU centers there either. You don't. You have nothing. And to me, you just built a $132 million hospital in 2011 in Abingdon. It would make sense to me to put a minimum of a level 2 NICU there and a level 2 trauma center there. And then what you have is you have the majority of this region within 30 to 45 miles of decent trauma and decent NICU services to help protect the lives of people here. So instead of spending millions of dollars to build pediatric emergency rooms that we do not need, that we will have trouble staffing, and a pediatric trauma center that we will have trouble staffing, why not take those funds that we currently have, build up the services that we have at the hospitals that are already built, right? That are already built, and then you start to work on some of the other issues that we currently have. Right, Tammy, and they might get them from as far as Wytheville, but Smith County is actually the boundary for the Ballad Health coverage. So just letting you guys know that. Right. There's so much, and nobody really knows how it's all going to work. What I do know is that if you downgrade these trauma centers and you take away this NICU, you put the lives of people in this region at great risk, at great peril, and it actually goes against the consensus. Okay, so follow me. Volume is one part. Volume is one part, okay? but it's not the only part. The consistent part that you want to look at is making sure that 90% of babies that are very low birth weight are born at a high risk facility, which if you take this NICU down from a level 3 and it's not even a level 2, you now don't have a single high risk birthing unit except for at Johnson City, because Bristol won't have one, Holston Valley won't have one, and that goes against the grain of making sure. And we know that babies that are born at non-level 3 and that are transferred, they have a hold on, Bubby. Babies that are born that are very low birth weight and they are born not at a level 3 facility, it increases their mortality rate by 62%. That is from the AAP, guys. That is for the AAP. I'm not kidding you. I just read it to you. And I'm going to create a group where I can post these documents, like where I've circled and highlighted them, so you can read it for yourself. Here's what's super important. There are things that you need to be doing for your community and for your well-being. It's, yes, saving the NICU is important. Yes, keeping the trauma center is important. What's really important for the longevity and the long-term well-being of this community in this area is to get the state action immunity that Ballad Health currently has removed. There is a direct conflict of interest between the state representatives in this in Tennessee and Virginia, because they passed legislation to be able to make this COPA even happen, right? So there's a clear conflict of interest. So that's the, yes, sir.
The oven needs to charge.
Okay, I'll charge it in just a second. So there's a direct conflict of interest. So we want the FTC to step in. We want the FTC to step in and have somebody else assigned to oversee the COPA, because the state is not doing it. The second thing that we would love to see happen is to have the monopoly broken up, right? Wellmont Health System had 8 other offers before the merger happened. So we want to see what those other offers were and see if we can't possibly get what removed. Okay, Donna, so we want to get, it's called a state action immunity. So here's what happened, guys. When they applied for the COPA, it's the Cooperative Agreement for Public Advantage. When Wellmont and Misha applied for the COPA, they did not qualify for it. The state representatives there, and I can tell you who they are, they submitted and passed legislation to get the COPA approved. Here we go. Let me give you their names. So they were Norris, Crow, Speaker Ron Ramsey, Eldridge, Harrison, Lundberg, Hulsey, Holsclaw, and Hawk. These folks submitted this piece of legislation right here. This piece of legislation, is an amendment to the existing COPA. Without an amendment to the existing COPA, Ballad Health would not have been able to do this merger. So those state representatives basically screwed you guys over, because the FTC came down here. They testified in front of the state health department on more than one occasion saying, do not do this. This will create a medical monopoly that is bad for your community. It will result in higher prices for care, lower quality service, and a hardship on your employees. I do, Tanya, have the verbiage available. I put it at the top of one of my other lives, but I will copy and paste it on the top of this one. Here's what you need to know. Because the state of Tennessee specifically, but even the state of Virginia, but because the state of Tennessee passed legislation making this COPA possible that did not already exist, they have proven a bias. The people who are overseeing the COPA, aka Gary Miller, his check comes from Ballad Health. So basically, Ballad Health is paying for their own stuff to be graded, right?
She just put something in her mouth.
Come here, Bella.
I think it was a piece of pizza, but...
Oh, hold on, guys. She's trying to run from me. It was, ow, don't bite me. Whew.
It was pizza.
It was pizza, but it was a big piece. Hold on, she's mad at me. Here, you can have this piece. Sorry, this is what happens when you have a 1-year-old that got a piece of pizza and about bit the bejesus out of my thumb. Everything is there, guys, but I will post it again for you, and I'm going to create a group for everybody. so that you know. But basically, we're going to say that the state cannot be trusted to oversee this COPA because they are biased towards it, and the people overseeing it on the ground level, bit the fire out of me, are being paid by Ballad Health. Now, Larry Fitzgerald is not paid by Ballad. He was hired by the state, but he only oversees the COPA part-time, not even full-time. There were other, yes, Tanya, there were 8 other offers that Wellmont received. 8 other offers. And what was supposed to happen, so check this out. You're welcome, guys. I'm giving it to you, sissy. Okay, so here's what was supposed to happen. Wellmont had 8 other offers, and what was supposed to happen was they were supposed to present to the FTC and to the State Department those offers and this merger side by side to prove that this merger was the best possible solution, like that it had greater advantages than any other option. They did not do that. And the FTC sent report after report after report that said they fell substantially short of doing that. And in fact, Ballad's reply to everything the FTC was, you haven't proven why we shouldn't merge. And Ballad said, listen, you have to prove, the burden of proof is not on us. Like, we don't have to prove why you shouldn't be a monopoly. You have to prove to us why this monopoly is the only legitimate option for the public. And that did not happen. And that is why the FTC needs to step back in and get this taken care of. So every day, guys, I'm not kidding, every day you need to be emailing the FTC and asking them to step in. And then there are other options that I'm exploring right now, but I'm not going to say them on this live. I will tell you this. I'm in talks with some folks to see how we can put a stop to this effectively and all of those types of things, okay? So I just want you guys to get... Well, Jeff, he didn't read any of the paperwork. The mayor of Kingsport told me that that being mayor of Kingsport was not his job, that he had a full-time job, and that being the mayor of Kingsport was public service, and that's why he has boards that he relies on to tell them what's in the best interest of their constituents. Susan, hold on, Suzanne, look, there's your girl. Look, Bella, say hi, Suzanne. Hold on, y'all. This is one of Bella's nurses, so say hi, Suzanne. Say hi. You see her? Okay, so Amber, that is something that we have talked about. That is something that we have talked about in terms of legal counsel. We're not sure like what the best course of action is there, whether it's a class action lawsuit that has to do with monopoly and antitrust violations. We're not sure. So, you know, there's a couple, actually it was the Attorney General's office who gave me the number to contact some folks about that. So, so yeah, that is something that's being talked about. Just got to kind of play this thing out. I've literally, think about it, guys. I've only been researching this and even aware of it for today's, I think, day 9 or day 10. 10 days. 10 days. We're just 10 days in and we're in for a long ride. So here's what you need to be doing to do your part. You need to email the FTC every single day. You need to be blowing up Gary Miller and his team who's over COPA compliance. You need to be blowing up Larry Fitzgerald, who is COPA compliance, as well as your attorney generals in both Virginia and in Tennessee, your representatives, Gary Hicks, Terry Kilgore, the governor of Virginia, who I understand is supposed to be a pediatric surgeon, I believe. This is not what I do for a living. Hey, lady, I haven't seen you in a minute. No, it's not what I do for a living, although I really wish it was. You know, the same way that I was passionate about the election stuff in Georgia is the same way that I'm passionate about this. Because it matters. This is the thing for me, right? This is the thing for me. Yes, Emily, he is. That is what I heard. I want people to prosper in this country. I just don't want them to do it at the expense of other people. I don't want corporations and the government to be able to be in bed together at the expense of our well-being and our livelihood. Like, that's just what I don't believe is okay. Yes, the email address for them all is on my other post, but I will post it up after this. I can tell you right now, the email address for the FTC is antitrust@ftc.gov. Antitrust@ftc.gov. I do have all of the telephone numbers as well and email addresses. I will put all of it up again for you guys, but that's what needs to happen every day. You all need to understand this COPA agreement is only for 10 years. So let's just say after 10 years, Ballad decides they want to close every hospital here. Ballad decides they want to sell you out to somebody else. Ballad decides whatever they want, they can do anything they want to. Anything they want to after 10 years, and it doesn't, there's no legal recourse. That's why we have to get rid of the state action immunity that they currently have. That's why we have to get rid of it now. So yeah, so this is the reality, folks. All of this stuff matters. All of this stuff absolutely matters. Okay, so I wanted to give you the information because he's so fond of quoting all of this volume stuff coming from the AAP, and I wanted to give you the other side of what the AAP and the fact that they are very adamant that using volume alone to predict outcomes is not accurate and not justifiable, and it should not be best practice. Okay, so I'm going to get off of here. I will post all of that other information. I appreciate you all very much. For those of you who have asked how you can fund and support me, I gave out my PayPal, but I will also post that as well. And I appreciate you guys. Actually, Katie, this is not an experiment. If you look at the history, I've done several other lives about Alan Levine. This is not an experiment. This is something that he has done before. Not the monopoly piece, but the way that they are operating healthcare. This is not an experiment. The last company that Alan Levine worked for was HMA, and the Department of Justice just settled their investigation, and HMA now has to pay $260 million in false claims. Having people be overbilled, having people admitted for no reason, having people having Medicare having to pay for things that were unnecessary, threatening people in their positions, in their employment positions, firing people for being whistleblowers. All of that Alan Levine has done before, and he did it at HMA, and he's doing it now. So just letting you all know that that's the deal. I'm going to let this little cutie pie say bye one more time. Tell him, say bye-bye. Bella, say bye-bye. Say bye-bye. Say keep our NICU. Say babies matter. Tell him, say babies matter. All our babies matter. All right, guys. I appreciate you very much. Be amazing. Be light. Be love. And we will talk soon. Peace.